Hi, everyone, and welcome to the show. Today, we are honored to have Dr. Robert Gabbay, known as Dr. Bob, a renowned endocrinologist and former chief medical officer of the American Diabetes Association, or ADA. He's going to be talking about groundbreaking advances in diabetes care that are transforming patient outcomes in ways we never imagined. We're going to start with a discussion about the recent STRIDE study, which revealed something incredibly remarkable. GLP-1 medications containing semaglutide not only helping to manage blood sugar, but also actually helping people with peripheral artery disease walk further and faster, as well as slowing progression of this debilitating diabetic complication. This represents a paradigm shift in how we think about diabetes treatment, moving beyond just controlling A1C to addressing the circulatory complications that dramatically impact the quality of life of these patients. We'll explore how these medications work. We're also going to be talking about the side effects. I know patients have a lot of questions about the side effects of these drugs, also their high cost, their limited availability, as well as whether other diabetes drugs might have similar benefits, such as metformin or Manjaro or Jardiance. So we're going to get into some of those questions. But Dr. Gabbay is also going to discuss some new exciting innovations in insulin pump technology and share how AI-powered digital twins are allowing patients to visualize the impact of lifestyle changes before they actually make them, just to give them a little bit more incentive. But before we jump into the fire, I want to welcome my amazing co-host, Dr. John Phillips.
Hey, happy when Tuesday, whatever day this is. I know we're pre-recording this. It's been a long day for me, frankly, but a good day. We're helping some people, and looking forward to the conversation. I mean, it was interesting. I was preparing for some cases, and somebody had asked me to discuss the risk factors of the folks that were on the cath lab schedule for their procedure, and you know, is it they're diabetics? I mean, there's so much diabetes. I want to say 30 million Americans, I think, or something along those lines. And
Yeah.
there's probably what 20 or almost 90 million pre-diabetics in the country. So this is a huge problem. And the fact that we can discuss this with an endocrinologist who understands the disease is going to be really insightful for me because we're always trying to help get folks, number one, get their diabetes under control, but number two, affect these pre-diabetics so they don't turn into a diabetic. So lots to talk about today, a lot of meat on the bone, so to speak. So should be a good show.
I think that we should literally jump right in. So let's get things started with a moment of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
So this is a simple quote from Eleanor Roosevelt, and I was trying to find something that was inspiring like I said, today was a bit of a long day, but she's quoted as saying, "The future belongs to those who believe in the beauty of their dreams." So I had a dream that I was going to be able to get through this blocked artery today, and unfortunately I couldn't. And it was really frustrating to me, but we made some progress. And I said to myself, this looks better at the end than it did in the beginning. And so in my mind, that's a victory. So I guess that I did believe in that part of that dream. So thank you, Miss Eleanor Roosevelt.
I love that. That is beautiful. And I see Dr. Gabbay nodding his head. Any thoughts on that, Dr. Bob? Let's call you
Yes,
Dr.
Dr.
Bob. I
Bob.
love that.
Sure. Yeah. I think it's a lovely quote. And, really, if one thinks about it, all of the innovation that's happened really all started with somebody having a dream and
Yep.
then following that through. And, that's all certainly in healthcare, there's, dozens of examples of that. So yeah, very inspiring quote for us to think about.
So
Wonderful.
I do have a dream. I have dream to cure diabetes. And if we cure diabetes, we're going to get rid of so much peripheral artery disease, not only in the US, but across the globe. One of the biggest most current diabetic complications that is leading to heart attack, stroke, and even worse, amputation as well. And I'm curious because, people all the time are out there talking about what led to this big diabetes epidemic. And I'm curious from your perspective, based on what you've seen, what your knowledge base is, how do you view the source, or do you see multiple sources for this current diabetes epidemic that we're experiencing that's leading to so much PAD?
Yeah, well, it's a great question, and I think part of it tracks, certainly for type 2 diabetes, which is 90 to 95% of people living with diabetes. It tracks with obesity. So as obesity has increased, so has type 2 diabetes. And then why is obesity increasing? Well, it's a number of factors. Certainly what we eat, and most importantly, how much we eat. And just look at an example of what a hamburger was in 1950 and what it is now, or a cookie then and a cookie now. Portion sizes have grown dramatically, and also the quality of food. We know that ultra processed food is more likely to lead to diabetes, and that's increased dramatically. So another big factor. Uh, and then it's what we eat, and it's also the physical activity side, and screen time. Where we see that increasing in children is also where we see obesity increasing in children, and type 2 diabetes increasing in children.
What's really sad is that there was an article in Science Direct just in the past, I would say, 6 months, which showed an increase in patients between the ages of 18 and 27 presenting in emergency rooms in advanced stages of peripheral artery disease known as critical limb ischemia. And the number one culprit they blame is diabetes. And coming up right here on the Heart of Innovation, we're going to get Dr. Gabbay's reaction to that. So don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAD, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link for circulation and pain. Left untreated, your leg might end in flame.
Welcome back, everybody. Thank you for joining us. So before we went to break, Kym gave us a nice little tease about folks showing up at younger ages to emergency rooms with critical limb ischemia. We're seeing the same thing with myocardial infarctions. I mean, younger and younger people. But, Dr. Bob, before you answer that question, I want to dive in a little bit to what you alluded to before about, well, the food has changed. Our kids are more sedentary. There's less exercise. So when do we need to intervene on patients? Or, I mean, are we talking obviously before high school? Are we talking grade school? Or are we talking, like kindergarten in the womb? When can we make a difference by intervening on our population? Because the number of pre-diabetics is just going to keep going up as the population ages and grows.
Well, I would say yes, 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 and yes. Even in utero, we know that women during pregnancy with gestational diabetes uh, are more likely to have their children develop diabetes. So it starts way back when, uh, and it continues all the way through. At the same time, I would say uh, um, any time is a good time to intervene. So if you've missed, kindergarten and they're in high school, that's fine. You can start doing something there. Um, Physical activity is really a powerful thing. Yeah, the other thing I would say is when you're thinking about children, it's really about the family. The intervention, whatever you're going to do is, if the kids are told to eat one thing and the parents are eating something else, that's just not going to work, right? So the whole family needs to get on board, and it's good for the adults as well to eat healthier.
And what about those families, though, that are on a budget? I hear all the time from patients, I can't afford healthy food. And yet you do have the dollar stores across the country that now have freezers and have lots and lots of frozen vegetables available for $1 each or $1.50 at the most. So that democratizes access to some of these healthier foods. But the question is then, are they choosing those healthier foods? Are they making it to the freezer section? Or are they just hitting the can aisle and going after the cans and the packages?
And is the freezer section way in the back where they go through the gauntlet of everything else before they get
And then
there?
and then they get claudication walking there, so they don't go there.
That's true. That's so not
Yes.
funny. It is
Well,
true.
no, but I mean, that's a great point. Like, you know how
Yeah.
it is. We
Well, as
go the
people
path of least
age,
resistance. Yeah,
mhm.
exactly. Yeah.
And no one's advertising healthy foods, right? Well, what do you see advertised is, watch a watch a ball game of any sort, or anything, and it's all the foods are not healthy, and no one's really promoting vegetables.
What about the beverages that people are drinking? I mean,
Yeah.
it's interesting and it's regional. You'll go to a store, in southeastern Ohio, and there's Mountain Dew everywhere. I went to a store and an entire aisle was full of Mountain Dew. And that's crazy. And it's that in and of itself is a problem, I think.
Yeah, huge. Sugar sweetened beverages is often one of the easiest changes that you can do that could make a big difference because it's just empty calories, right? And to your point, if you look at the availability of water or sparkling water or other alternatives, um, there's huge cases of everything else, and then a little tiny section where you'll find something that is not sugar containing.
And I love your point that it really does come from the family and what the parents are doing, and that'll trickle down to the kids. Because I know for me, clear up through sophomore year in high school, my mom actually made us take a thermos of milk to school or water. That was our choice. And it wasn't until my junior year that she started buying some of those Capri Suns and letting me take those to school along with water. As long as I had the water bottle along with it, I could have one pouch of Capri Sun. But nowadays, you see so many kids just bringing cans of soda to school. And I was out to dinner just the other night, and the parents were ordering kids soft drinks. I was never allowed to have soft drinks, except, once in a while when we went out to a special dinner, I could have a Shirley Temple. Remember those?
Yes, indeed. Yes. Well, I
Well,
mean,
kind
oh, go ahead. Take
Well,
us.
coming up right here on the Heart of Innovation on that note, let's put a cherry on top of that. We're going to have more with Dr. Bob. We're going to be talking about all of the medications to help these patients and just how young these drugs are being prescribed for these patients that are suffering from prediabetes and especially type 2 diabetes so that they don't end up in the emergency rooms in their 20s with their leg on deck for amputation. So stay with us right here on the Heart of Innovation. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just cut your leg off?
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back, everybody. Thanks for joining us. So before we went to break, I think Kimmy touched on something important, and Dr. Bob is going to walk us through this. So walk us through the medications for someone with, let's say, type 2 diabetes, because again, that's the vast majority of patients. Like, what is the threshold with respect to my hemoglobin A1C and my blood glucose levels to call me a diabetic? And what do you start me on, or is it a diet, and escalate that for us so our listeners understand, please?
Sure. So, when we think about type 2 diabetes, the screening for that should start really for everybody at age 35. And if you have sort of risk factors, even younger. So many people are not getting diagnosed with diabetes or pre-diabetes. The cutoff is a blood test called an A1C of 6.5. So that blood test is an average of blood sugars over the last 3 months. So it doesn't matter what you ate or didn't eat that day, or the week before, or what you ate. So it's a really easy screening test, and I recommend for all of your viewers to get that test done. When it comes to medications, the shift has been not only medications to control blood glucose levels, which are important, but also those that have special impact on reducing complications. And that's the class of drugs called the GLP-1s, which I'm sure we'll talk more about, and another class of drugs called SGLT2. You can see these were not made by marketing gurus. Those aren't the easiest names to go by, but they are the two classes of drugs that we may consider using regardless of what blood glucose control is needed, because they can prevent complications of diabetes.
And so when you're talking about what is it, what'd you say, SGL?
SGLT2.
Okay, yes.
Sodium
Would those
glucose,
be
yeah.
Oh my goodness.
Yeah.
It really does. Wow. So the Manjaros of the world, the Jardiances, is that
So
kind of what they call?
Jardiance is an example of an SGLT2. Yes,
Okay.
exactly. Yeah.
And that just handles that, strictly just says, hey, I am targeting the A1C and we're going to lower that.
Well, so that drug, the SGLT2s, if you have heart failure or you have kidney disease, those medications specifically treat heart disease and kidney disease while also lowering blood glucose. So they're really special for that use.
Gotcha.
So
And they're now even being used for people without diabetes that have heart failure.
So, like, if you're a primary care physician and you see your patient, routine physical, they get their hemoglobin A1C 6.5, are we not starting metformin anymore? Or are we pivoting towards some of these more advanced therapies?
We may start metformin. First of all, let's say, all people, when they're diagnosed, need to learn more about diabetes so they can take better care of themselves. And diet and physical activity and monitoring their blood glucoses are important things throughout the journey of diabetes. When you get to the point of needing medications, metformin is often the first line drug, but if you have heart failure, you should be on an SGLT2, whether you're on metformin or not, no matter what your blood glucose is. And there's an argument for people living with obesity and heart disease that they should be on a GLP-1 regardless of what their A1C is.
And so let's talk about those GLP-1s, because they seem to be, as I talked about in my intro, especially the semaglutides are making a huge difference in walking distance. I talked about what Dr. Banaka, who was the PI of the STRIDE trial or STRIDE study, as we talked about, that he was saying, part of it was the fact that blood becomes thick and syrupy and, clotty when your A1C is high with all the sugar in there. And sugar molecules also end up damaging the artery walls. So you lower that, and your blood's going to be able to get through those narrowed areas, including the collateral vessels that reroute blood flow around those blockages in the main arteries. And you're slowing progression of disease because you don't have as many sugar molecules in there damaging the arteries, leading to plaque buildup.
Kym, that's true. And these drugs seem to do something beyond that, because they were able to see an effect just in 1 year. And typically for vascular changes as a result of a change in A1C, it takes several years to really be able to detect that difference. So the effect on blood glucose was part of it. The effect on weight was part of it. But there was also something else. And that's been the intriguing thing about this class of medicines, is they seem to do things beyond just what we know that they do, reducing weight and reducing blood glucose.
So they don't know the entire mechanism of action by which it really helps people to walk further and faster. I mean, even weight loss, you could argue, you lose a little weight, you get a little more pep in your step as well. But I wonder if there's a little bit of a vasodilation aspect of it that might help as well. So that'll be interesting to see as more studies are done to see if they can really, pinpoint that mechanism of action. Although, right, Dr. Phillips, it could be a culmination of everything.
I think there's something in the anti-inflammatory range that's probably leading to this. It's a pretty impressive, like we talked about. We haven't had anything in 25 years that, at least from a P.A.D. standpoint, that's really improved symptoms, and the GLP-1s did. And to Dr. Bob's point, in a year. And I think the effect lasted even after they stopped the medication. But the question I always have is, are we going to be on these the rest of our life, or is the patient potentially? I don't know, right?
Yeah, and I hear that question a lot, and I often think, well, we don't ask about statins for cholesterol or blood pressure medicines in the same way. If I start a medication for my blood pressure, do I always need to take it? Well, if you want your blood pressure to be good, you probably do. If you stop it, your blood pressure is going to go up. So this is like, medicines work when you take them, and they don't work when you stop taking them.
I did see a study that came out that talked about exactly that you really don't want to. Once you start these GLP-1s, you don't want to stop, because they're seeing patients just spring right back and have the same issues with weight and with glucose as before, and it almost comes back with a vengeance. So coming up right here on the Heart of Innovation, we're going to have more on these GLP-1 medicines, and we're going to talk about those side effects versus the benefits. So stay with us right here on KDOW. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD, or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years, and my husband had to quit work.
I didn't know what to do at this point, because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go
through all that.
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back, everybody. So before the GLP-1s get put in the water, Dr. Bob, we should probably talk about how to dose it correctly, because it's a gradual, right? You titrate to a higher level, and then hopefully you back off a little bit. But assuming the patient doses it correctly, at what point will they exhibit some of the side effects, the GI upset and some of the nausea and things of that nature? Is it right away, or does it occur as you titrate up?
It can happen at sort of any point. Some people after the first injection will notice it. The key is really starting slow and gradual. So at the lowest dose for an entire month, and then the next dose typically for another month. And so it takes time to get to a really effective dose where you'll see the benefits, like on P.A.D. in the study that we talked about. Most people can, and the side effects get a bit better if you can tough them out. But there are also things that you can do to minimize that. And one of the things I always tell people to do is, if you're eating, eat half your meal and then stop. And wait a few minutes and let your brain catch up to your stomach, because you may be already full. If you're not, go ahead, eat the other half of the food. But many times people power through their meal and they end up so full because your stomach's not emptying, which is part of the way these medicines work. So eating slower, taking a break, starting at a low dose, gradually going up can help with the side effects.
That is interesting you say that, because I would imagine, I mean, it works because you're supposed to be able to eat less when you're taking these drugs, right? You're supposed to be
Yes.
less hungry. But if people are used to, especially in the beginning, eating very large portions and they like the taste of something, so they
Yeah.
finish the plate because they just crave that taste, then that could, I would imagine, lead to the stomach problems that we've been hearing.
Totally.
There are concerns that one patient who chooses to be anonymous is mentioning in regards to contaminated versions of Ozempic. And I guess NBC News did a report on it, that there were concerns of some wannabe drugs coming in potentially from China, and what's being done there, and how does a patient know if they're getting the real thing? I mean, do you find that this is an issue in real pharmacies, or are we only seeing this mainly in the compounding pharmacies?
That's where we're seeing it in the compounding. If you're getting the brand in the packaging that comes from, the two manufacturers, I don't think there's any concern. But because of the shortage, there's been sort of permission to compound, and the compounders are a little bit of the Wild West. There's some very responsible ones, and then there's some that just sort of say there's a quick buck to be made, and we're just going to ship whatever. And so buyer beware.
Yeah.
How would you know? I mean, gosh, that's really tough to know where they're
It is tough,
sourcing
and
it.
that's where the safest thing is to, like with any medication, to get it through a prescription at a pharmacy, because those are all regulated, inspected, all of that.
And what are the efforts being done, just as with insulin, to lower the cost for patients who are most vulnerable? I know that there's been a lot of work done by ADA and yourself and other organizations.
Yeah, for insulin, there's been some good success of capping at $35, which still can be a burden for people, but much better than $500. So there has been progress there, where we need to figure a solution is for the access to the GLP-1s, that are $1,000 or more a month and, unaffordable to many people and not covered by, insurance under different circumstances.
Can we go to insulin really quick, and then we're going to move on to some other innovations that we had mentioned in the beginning? And I know Dr. John is itching at a couple of things when it comes to diabetes management. I've seen a lot of patients end up as type 2 with insulin. Where does insulin fall in terms of the line of prescriptions for people with type 2 diabetes? What are the indications?
Yeah, usually we try to use, tablets, uh, GLP-1s, and then insulin. Unless somebody's blood glucose levels are so high that they're really having bad symptoms, and then the quickest way to bring glucose down is with insulin. So generally it's late in the course, but some people aren't diagnosed. For a long time. They could have diabetes for years, not realize it. And when they first show up, they're already at that point where their blood glucoses are in the 300s and 400s. And then really the insulin is likely to going to be the thing that they need.
Dr. Bob, before we go on to talk about some of the continuous glucose monitors and things of that nature, real quick, the term sarcopenia, so the muscle loss that occurs with these meds, is that real? And what do you think that's from?
Yeah, I mean, I'm glad you brought that up because that is the other sort of side effect of these medications is not only do you lose fat, but you lose some muscle. And that's actually true of any kind of weight loss. You tend to lose fat and muscle, but now we're measuring this and being more cognizant of it. And that idea, sarcopenia, is the loss of muscle, particularly a problem because as we age, we all tend to lose muscle. So the things you can do to prevent that are one, to do some kind of strength training, and it doesn't have to be extravagant, but using your muscles will prevent some of that muscle loss, and eating enough protein. Because people end up eating a lot less, it's easy for them to not eat enough protein under their new sort of smaller portions that they're eating. So being mindful, like of getting enough protein, and so another important consideration.
And we do have a quick question coming in from one of our viewers. Kay, how do you combat insulin resistance for a type 1 diabetic with a C-peptide of 1486? Pretty specific.
Oh, pretty specific. So I'm not sure that this for people with type 1 diabetes, they tend not to make any insulin, and therefore C-peptide, which is part of insulin when it's made, tends to be very low. That said, there is use of treatments for insulin resistance in people with type 1 diabetes. We don't think of type 1 diabetes as being insulin resistant, but about a third of people with type 1 diabetes live with obesity. And so these medications that treat obesity should be effective also for individuals with type 1 while we adjust their insulin appropriately.
Have you heard of someone actually no longer responding to insulin being a type 1 diabetic?
It's extremely rare. There are cases reported, and it can be that they have an immune reaction to insulin that binds it up or blocks the insulin receptors. So there are some rare cases. That said, many people that are very resistant to insulin may need incredible amounts. And I've seen patients, on 500 units of insulin because that's all that's what it takes to work. And so there are some, going to a specialized center that can look into some of these very unusual cases would be my best suggestion.
So I think it's good time. We have Beth, who's in our live studio audience, asking about the wearables for diabetes management. And I know, Dr. Phillips, you've been itching to ask a question about that. So go ahead.
No, yeah. I mean, I think you see a lot of stuff out there and you see people wearing these devices. What are your thoughts on them? And should every diabetic be monitoring their glucose continuously?
Well, I think every person with diabetes should be monitoring their glucose. Now, how much you need to monitor and whether you need a continuous glucose monitor is the question. Uh, the recommendations are anybody on insulin should have a continuous glucose monitor because it can detect when you get too low, alarm you, all of that kind of stuff. But for many people, having the information, and I don't have diabetes, but I've worn them, and you learn a lot about the impact of what you eat and physical activity. One day I ate a bagel and I'm like, wow, my blood glucose just shot up. I mean, it didn't go to a dangerous range, but how quickly it rose from a bagel. So you start to learn how your body reacts to different things, and that can really help people with diabetes to think about what they eat and adjust what they eat.
I've heard that you can buy them at the, local pharmacy.
You can. There are two brands of them available, and they're available over the counter. They're slightly different than the ones that people with diabetes use, mainly because they're not detecting low blood glucose, because that's not an issue typically for people without diabetes. But they can also really be informative. And, there are many folks that just like to sort of be able to know what's happening in their body. I tend to be that kind. I wear an aura ring and, and like to be able to measure various things. So
Does that ring work?
yeah, it's actually remarkably accurate. There've been some good studies with it, and I'm not endorsing any one. There are a whole bunch of different ones, but they've gotten better and better. They're really good for sleep, because that is another important thing for people with diabetes. Having good quality sleep for all of us, really.
Yeah, that's true.
And they're good for that, and also incentivizing you on activity and measuring heart rate and a bunch of things.
I almost wonder if these diabetes, these monitors should be brought into the classroom for, elementary school and even at the very least high school age kids in their health class, and have them actually wear them for a week and journal about it. And maybe some of the lessons learned and changes that they will make because of what they
Well,
learned. I think that can make a huge difference.
you touch on a huge point because it's so often, oh, they're young, they can eat whatever they want. And we don't really think about that. And like you'd said, Dr. Bob, it starts with the family, but oh, she's 12, she can have M&Ms and Fritos and McDonald's and that's not going to hurt them, but it does, right?
Yeah, and I like that idea of knowledge is power.
I mean, they could, we have friends that will say, oh, yeah, they're active, they're in this sport and that sport and whatever. So they can eat all the carbs they want. They can have an entire plate of spaghetti if they want to, because they'll just burn it right off. And I think that attitude is what leads these same kids to ultimately be making poor decisions as adults and eating the same big bowl of spaghetti that they could eat when they were young, supposedly because they burned it off. Later on in life, they just can't do it, but they still do it, which leads to the problems in the situation we're in.
Yeah, I mean, look at ex-football players, right? They eat while they're playing and they can eat anything, right? But as soon as they stop playing, wow, they put on a lot of weight. And same thing with kids as they stop being active. So yeah.
Well, coming up right here on the Heart of Innovation, we're going to have other incredible, groundbreaking innovations that we're going to talk about with Dr. Bob. So stay with us right here on KDOW in the Heart of Innovation. Don't go away.
I had a patient who had surgery, had bunion surgery actually, was in their late 40s and went perfectly normally. And by the way, this was a second opinion. And within 24 hours, this foot turned hot red. No diagnosis of circulation issues. Very typical 40 plus something woman. Foot turned cherry red. Unbelievable pain, burning, itching, migrating up the leg. Could not figure out what was going on. X-rays, did they leave
material in? Did they break a tip off a scalpel in? Was there tissue left in? Was there an infection? Could not figure it out. And they were cast. This patient went to a dermatologist. This patient went, I don't know if they went to a vascular, I can't remember, but they were accusing the whole thing of vascular compromise. And they were starting to talk about doing some aggressive vascular care. They came to me and I looked at the wound. And the first thing I said is, why are your stitches still in? We need to open this wound. The surgery had only happened less than a week ago. The wound had not healed. So we got to take these stitches out. Oh, I don't want to do that. I said, listen, we got to see what's going on. If there's something that wants to come out, and very honestly, I need to look what's going on inside. So I took the stitches out and I looked around. I didn't see anything either. And I'm talking back and forth with the patient. And I said, this almost strikes me as an allergic reaction, which is crazy. Tell me the medications you're taking. Did the doctor give you anything unusual? And believe it or not, the patient happened to mention they were allergic to nylon. Now, I don't know about you. I have never in my life run into anybody that's allergic to nylon. But guess what sutures are made of that close your skin? This woman had about a foot of nylon suture in her skin. So they were starting to talk about all this aggressive, invasive vascular work. They're talking about the possibility that maybe this toe is going to be lost. I mean, they're filling her head with all sorts of things. We took the stitches out. Within 24 hours, the foot was fine.
Wow.
Second opinions. Looking out of the box a little bit. I'm not smarter than everybody else, but I had the advantage of everybody else thinking of everything and it not working. So I had to think out of the box.
So wrapping up the show here, thanks for joining us. Dr. Bob, I want to get your thoughts. Where do you think this epidemic is going? Are we on the right trajectory to reduce those that are going to have prediabetes and ultimately diabetes, or are we going on the wrong direction and you think is this just going to get worse?
Well, I tend to be optimistic, so I'm hopeful that we'll move in the right direction. I think, you know, the changing of eating patterns is going to be an important thing, and I'm not sure how quickly that's going to change. The availability of these new medications like the GLP-1s to help control weight has real promise, and they've been demonstrated to take people who have prediabetes and normalize their blood glucose. The challenge, of course, is access to them. They're expensive. The disparities that already exist in healthcare are likely to just widen, those that can get it versus those that can't. And so that needs to get sorted out.
And we have a couple of folks that are watching who are type 1 diabetics and asking about the innovation in insulin pumps. Can you talk about what you're most excited about there?
Yeah, well, we now have insulin pumps that can respond to the continuous glucose monitoring devices and inject the right amount of insulin to control blood glucose. What they haven't been able to do well is manage when you eat and get enough insulin into you quickly. Well, just at the latest diabetes technology meetings in Europe, there were two examples of not having to take insulin with meals either. And so really sort of largely running on autopilot, and that could make a big difference. I think the other big exciting thing is cell replacement therapy and then ultimately a cure to be able to put back the insulin producing cells that people are missing when they have type 1 diabetes and potentially cure. And that's getting closer.
Really? Have they actually tested that in humans?
They have. So far, the challenge has been that you need to be on immunosuppressive therapy because it's a transplant of a foreign cell. But they can take a blood cell, devolve it into a stem cell, and then grow it into cells that produce insulin and put them in people. And there have been several people that have been insulin free for 3-4 years as a result of this. There's still a lot to work out, but the proof of concept is there.
What is your number one suggestion or recommendation for somebody to change the trajectory of their life with respect to developing pre-diabetes? Is it changing your eating? Is it exercising more? What is it?
Ooh, that's a tough one. I think the combination of eating and exercise. If you have obesity, it's more effective to control what you eat than it is to exercise in terms of weight loss. And so that's where I would focus.
I'm curious about the AI digital twins because that fascinated me.
Yeah, it's a fascinating and incredible thing. We can take the data around an individual, create sort of this a digital twin that then can be tested and sort of say, well, what would happen if this individual lost 5 pounds, or what would happen if their diet changed in this way? With AI, we're getting the ability to do that kind of thing. And that can be a nice motivator for individuals to put their digital twin through the different scenarios to find out what's going to be most effective.
I love it. So many amazing innovations. Dr. Bob, we have to have you back, but thank you so much. We are out of time. We really appreciate you. And the best place to go for information on innovation in diabetes is, I would imagine, diabetes.org.
Yep, the American Diabetes Association, great site. And I post a lot of things on LinkedIn, so you're welcome to check that out as well.
Fantastic. Thank you.
Walking down the street, feel the birds let in. Simple strolls turning into fights within. Don't ignore the signs, your body's playing loud. Time to act now, stand up and be proud. Peripheral artery disease is more than just an ache. It's your heart's message, don't let it take a break. Seek the help you need, your life's worth the fight. With awareness and care, we'll make it right.